All right, you guys, I'm back to talk to you about controlled substances and the schedule of controlled drugs. So in the previous video, we were talking a little bit about the difference between a regular prescription drug and a controlled substance, but I want to dive in a little bit deeper here to this topic. So as I mentioned, the schedule of controlled drugs has 5 levels, starting with Schedule 1 and ending with Schedule 5, and then of course 2, 3, and 4 in between. Schedule 1 drugs are going to be the most stringently controlled, and Schedule 5 drugs are going to be the least stringently controlled. The Attorney General of the United States is responsible for putting these drugs on the schedule and deciding where they go, Schedule 1 through 5. And how this is determined is based upon the medical usefulness weighed against the potential for abuse. So the lower the medical usefulness and the higher the potential for abuse, the higher up on the schedule. So a Schedule 1 drug would have no limited to no known medical usefulness and a high potential for abuse. So let's talk about them individually. Schedule 1. So Schedule 1 drugs, they are not going to be used at all with the exception for research. So you're only going to see Schedule 1 drugs in research facilities. You are not going to see them in CVS or Walgreens or anywhere. Nobody's going to be writing prescription for Schedule 1 drugs anytime soon. So one thing to know though about this is in the next video, we're going to talk about drug testing and how that's all done. All drugs that are being tested and are ultimately trying to get to market, whether they're going to be a controlled substance, a regular prescription drug, or an over-the-counter drug, everything starts off as a Schedule 1 drug. And once the whole testing process is done and the data is evaluated, then we determine if a drug is going to be a scheduled drug, and if so, where it's going to fall on the schedule. Or if it's just going to be a regular prescription drug like an antibiotic, or if it's going to be an over-the-counter drug. But everything starts off as Schedule 1, so that's something you want to remember. All right, so if they have no therapeutic value, even with medical supervision, or their potential for abuse is too great, then they're going to stay as a Schedule 1 drug. And again, you're only going to see those in research facilities. So currently Schedule 1 drugs are heroin, hallucinogens like LSD, marijuana, although this is very sticky, but marijuana still, as of today, at the time of this recording, is still classified as a Schedule 1 drug, even though all the other stuff around marijuana is very confusing. That is something we probably will see rescheduled, but as of the time of this recording, just recently the DEA decided to not reschedule it and to keep marijuana as a Schedule 1 drug. All right, so if somebody in the research facility wants to do some testing on a Schedule 1 drug, they have to apply to the FDA for clearance in order to use this Schedule 1 drug. Okay. And we're going to talk about this later, but anytime you're testing any drug, whether it's a Schedule 1 or otherwise, in order to test a drug, you have to get from the FDA what we call an investigational new drug exemption, or an IND. And we'll talk more about that later on. All right, so those are Schedule 1 drugs. All right, Schedules 2 through 4. Now these can be ordered with a prescription. They're scheduled drugs, which means that the person ordering them has to have a DEA number, right? And we already talked about that DEA number. There's a typo there. That's changed, and I didn't catch it. Sorry. The DEA number is now renewed every 2 years. It used to be yearly, but now it's every 2 years. And again, we said this before, but records need to be kept for 2 years for any scheduled drug. The DEA, actually, this is the Drug Enforcement Agency. The DEA sets quotas in terms of the quantity of these scheduled drugs that can be manufactured and distributed. And theoretically, the DEA monitors distribution and sales of all controlled substances. And at any time, they can request records from physicians or pharmacists or manufacturers. So there's sort of a fair amount of control, especially as we're up in the upper portion, like schedules 2s and 3s. So the scheduled drugs, especially scheduled 2, used to have to be, the prescription had to be written, which it still does have to be actually written. And it used to be on a triplicate form, but now they have a new watermarked form. It's a security paper. I'll show you a picture of it in a little bit. So that's schedules 2, 3, and 4. Schedule 5 drugs, these are sometimes also called signature drugs. So this is a little sticky. For Schedule 5 drugs in California, you still need a prescription for a Schedule 5 drug. It's a federally controlled substance. Schedule 5 drugs usually have a small potential for abuse and or dependence. So not a high potential for abuse and or dependence. But because they do have that potential, they're still classified as a scheduled drug. Oftentimes, a good example of a Schedule 5 drug would be like a cough syrup with codeine in it. The codeine is the narcotic, and that's why it's scheduled, and then the cough syrup is not. In some states, like Arizona, for example, a Schedule 5 drug can be dispensed by a pharmacist. But that doesn't mean that it's an over-the-counter drug, and this is something that people get confused about. If it's Scheduled 5 in Arizona and a pharmacist is dispensing it, the pharmacist still has to keep the records. They still have to go through all of that, right? But it doesn't need a prescription from somebody with a DEA number. But that's not the case in California. In California, Schedule 5 drugs still require a prescription by someone licensed that has obtained a DEA number. All right, so in the case of the pharmacy, which doesn't happen in California, although that will probably change, I would imagine that will change in the next few years, but the pharmacy has to keep the records, right? So somebody's got to keep the records of these things. So as I said, California does not permit Schedule 5 drugs to be dispensed without a prescription. All right, so those are Schedule 5. This is a form. This is the watermark form. Excuse me. It's all kind of blacked out, but if you were to try to fax this form, it would fax with a void, like I wrote on there, but it would fax with a void across the paper, so it's watermarked. What else do I want to point out to you on this? So if this was, if you're writing a prescription for a Schedule 2 drug, it has to be written. You cannot phone in a prescription for a Schedule 2 drug. It has to actually be written. And the physician's name, address, sorry, there's a typo there, and DEA number would have to be on the prescription. All right, so there we have it. That's what I was just talking to you about. Most people write their prescriptions for scheduled drugs on the triplicate form, but it's absolutely required for Schedule 2 and Schedule 3. And that's because we're tracking those. Okay, so I think I've told you this already, but drugs are placed on the schedule based on their usefulness, weighed against their potential for abuse. So here's an example. Here's some examples, and you don't need to memorize this, but this is just something to be aware of. And this is some of the drugs that fall on these different schedules. So as I said earlier, schedule number 1, we have things that you're never going to see, at least anytime soon. You're not going to see prescriptions written for these agents in CVS or wherever. I can't speak to marijuana because that's just confusing. So Schedule 1, when you look over on the left, you see the abuse potential is the highest, of course, and the therapeutic use on the right. And for Schedule 1, we don't have any acceptable medical use. Therefore, no prescriptions are going to be written. They may be used in a research facility, but you would have to petition the FDA for approval. Schedule 2, you are going to see these. Schedule 2 drugs, these are where a lot of our narcotics fall in. oxycodone, methadone, amphetamine, cocaine, and cocaine is used here as an adjunct to anesthetic, so you're not going to really see that. We've got methylphenidate, that's Ritalin, PCP. Again, there's very limited uses for PCP, and a lot of our short-acting barbiturates are Schedule II drugs. So there is some medical usefulness, but there is quite a high abuse potential. So these are going to be our most tightly regulated in terms of prescription writing. These are the ones that you're going to have to write a prescription. You're not going to phone it in. If you're in a situation where you can phone it in, like in the middle of the night in a hospital, or for example, the written prescription will have to follow within 72 hours. Schedule 3 has a moderate abuse potential. And this is where we have some of our intermediate acting barbiturates. Ketamine is kind of a PCP-like drug. We'll talk more about that later on. Then we go to Schedule 4, lower abuse, but still have a potential for abuse. I cannot stress that enough. Just because it's Schedule 4 does not mean that it does not carry a risk in the abuse and or dependence. And we're going to talk a lot more about this when we talk about unit number 6. This is where drugs that are used a lot are found, and these are our benzodiazepines. This is where Valium comes in, Xanax comes in, those guys, Tramadol, some of our sleep meds come in here. So Schedule 5, I mentioned already, lowest potential for abuse, but still has a potential. Okay, so I want to focus our attention over here to Schedule 2, 3, and 4. So we have some of our prescription writing rules here. So there are normally no refills can be written on a Schedule 2 drug. So if you need, so it's generally no refills or a 30-day supply and no refills. If somebody needed more than a 30-day supply, they'd need another prescription, is what we're saying here. There are some exceptions to that, but that's how Schedule 2s generally work. Schedule 3, less stringent control. They can have refills. They're limited to 5 refills allowed in a 6-month period. So the duration of the prescription cannot extend past 6 months, and they can't include more than 5 refills on that original prescription. At that point, they would need another prescription. The same for Schedule 4. Everything is the same. The only real difference there is in terms of if somebody's caught with somebody else's medication, the penalty is more stringent for a Schedule 3 than a Schedule 4. And then Schedule 5s, we do need to write a prescription. They keep the records in California, that is, but it's a lot more open-ended in terms of what you can do with that. So I think this is going to be summarized on these slides as well. So highest potential for physical and psychological dependence, and those are 2 different things, although they are related, and we'll get more into that later on. So again, they cannot be refilled, maximum of 30-day supply. You need to have another prescription if you want to extend that, and the prescription needs to be written on the security paper. So remember I said that you cannot phone them in, but if you're in a managed care kind of a setting, like a hospital, for example, and on the weekend or something, or at night, then a written prescription has to follow within 72 hours. Schedule 3, the moderate to low physical dependence. We can still have some kind of high psychological dependence, and we're going to get into the differences between that later on in our class. But here we've got our barbiturates, some of our codeines with narcotics, those kinds of things. So again, I said that they can have, this is going to be the same for Schedule 4 as well, 6-month duration or 5 refills. And they can phone in or fax with these guys. Okay, but the DEA number is always going to have to be included. All right, so Schedule 4, we just sort of talked about this. This is where a lot of our benzodiazepines fall in line. Same kind of prescription issues as Schedule 3. I don't know why I put that in there twice. So Schedule 3 and Schedule 4 are the same. The penalty for possession is the big difference here, illegal possession. And then, and I think this box in the bottom is kind of an important one. So how are these the same, 3 and 4? So they're the same in their, I'm giving you a second to think about it. They're the same in their prescription writing procedure. How they're different from each other is if in terms of illegal possession. So if somebody is possessing a Schedule 3 drug illegally, this versus a Schedule 4, the penalties are going to be more strict. And how these Schedule 3 and Schedule 4 drugs, and Schedule 5 in California, we could put that in there as well, is different from a regular prescription drug is that they have a potential for abuse. Even if it's low, if it has a potential for abuse, it's a controlled substance. It has to be put on the schedule. If it doesn't, so the difference here would be like a benzodiazepine, like let's say Valium versus oral contraception, right? That's not something someone's going to abuse, or an antibiotic. That would be a regular prescription drug. You still need a prescription for it, but it's not a controlled substance. So the people who can write those prescriptions are going to be different. They do not require a DEA for the regular legend or prescription drugs, DEA number. All right, so let's look at a couple of labels. So here we have 2 different medications. Just eyeball them. So the label right there, this is the separation, right? So this is one label, this is the other. So we see the names, and we're going to get into the difference between names and all of this. So this is just for a primer. This is the brand name or the trade name, Ritalin, sustained release. This is how much is in each capsule, 20 milligrams. This is the generic and or official name, which is methylphenidate hydrochloride. It's designated how it's formulated in the USP. This right here, this big C with 2, tells us that that's a controlled substance, and it's Schedule 2. On the far side, Restoril is the brand name. Temazepam is the generic / official name. Those are the same. It's formulated by standards outlined in the USP. Each capsule is 7.5 milligrams. This is also a controlled substance. It's a benzodiazepine. It's a Schedule 4, controlled substance. If you didn't have these guys here, and you just had this label, and this is the only thing you saw, that's the legend. So if it just says RX only, then it's just a legend drug. If it doesn't have those big Roman, those capital C's and those Roman numerals. Excuse me, I have the hiccups. Hopefully that makes sense to you guys. If it doesn't, make sure you ask. So here's a couple other ones. All prescription drugs have to have the label, the legend, So looking at these labels, look, we have atropine over here, how it's given. This is an injection. It's USP. And right here, the caution, federal law prohibits dispensing without a prescription. That's the legend. You don't see any C with any Roman numerals. This is not a controlled substance. Indomethacin over here, we see the abbreviated legend, RX only. Those are legend drugs. Historically, it had all of this written, but since we abbreviate everything now, we're abbreviating it to RX only. If it has that means it's a legend drug. It's a regular. So these are called legend drugs or regular prescription drugs, not controlled substances. That's the difference. Okay. So I'll put it all up here. This is the deal. Regular prescription drugs. The state determines how they're going to be, who's going to get to prescribe what. So, different levels, like PAs, nurse practitioners, physicians, they're able, if their license if by their license they have a particular formulary, any drug on their formulary they can prescribe. And many of those are going to be regular legend drugs. Controlled substances, however, even if you've got a, let's say, a physician that doesn't have a DEA number for whatever reason, then they wouldn't be able to prescribe a controlled substance, but they could still potentially prescribe a regular legend drug. You don't need to keep the records, all of that. The controlled substances are different. We're monitoring these. This is a huge problem, which we'll get into later on in our class, but they really pay much more attention to this. The Department of Justice tracks. There's a database that all this data theoretically goes into, and we have the information in terms of who's getting them, who's prescribing them, who's getting them, and how many people are getting all these different drugs. Okay, so that's the controlled substances and the schedule. So I'm going to cut this at this point. I'm going to come back and talk to you about drug testing and drug approval and the process around those two things.